Welcome again to Medical Lecture Series. We are proceeding with our discussion of the proliferative disorder of white blood cell, and today we are going to discuss lymphomas. Remember, our last discussion was about leukemia. So before I proceed, I would like to advise ourselves on where we started when we were discussing leukemia. Generally, we said disorder of the white blood cell can lead to increase the number, that is leukocytosis. Leukocytosis, this is increase the number of white blood cell. We said another category, they can lead to leukopenia. Leukopenia means decrease the number of white blood cell. So when we are talking disorder of white blood cell, we can have those which lead to decrease the number and those which lead to increase the number. And we said in lymphoma and leukemia, we are going in the direction of increase the number. That is leukocytosis, increase the number. In leukocytosis, we said WBC, when they increase the number, they can be due to two reasons. Number one, they are reacting against infection, that is reactive proliferative, and they can be due neoplastic, that is neoplastic proliferation. In neoplastic proliferation, WBC are highly dividing because the cell has lost control on cell division. As far as leukemia and lymphoma is concerned, we are going the direction of neoplastic. Leukemia and lymphoma are not due to reactive. Remember, reactive proliferation, as I said in the leukemic session, it was due to reaction against microorganism. And when we said when you have reactive proliferation, it can be simple leukocytosis or leukocyte reaction. You can just revise the lecture of lymphoma if you didn't get this, if you didn't capture this concept very clearly. For now, we are going in neoplastic. We said neoplastic proliferation of white blood cell can either be leukemia or lymphoma. So we discussed leukemia in the previous session, so you can go and revise about leukemia, but currently we are going now to start discussing lymphoma. So by so saying, I would like to say now welcome to lymphomas. Okay, what is lymphomas to start? We say lymphoma, this is a neoplastic proliferation. As I said, it is the neoplastic proliferation of white blood cell which involve lymphoid tissue. Remember when we are discussing about leukemia, we said leukemia was also a neoplastic proliferation of white blood cell, but leukemia was involving blood and bone marrow. Blood and bone marrow. But lymphoma is also a neoplastic proliferation, but it does not involve blood and bone marrow. It just involves lymphoid tissues. When we are talking lymphoid tissues, of course you remember lymph node. Of course, that's what we are talking about. So it's very easy to differentiate leukemia and lymphoma, but generally leukemia and lymphoma, they are both neoplastic proliferation of white blood cell. But the only difference which make leukemia and lymphoma, that is leukemia, it involves bone marrow and blood. When you measure the number of WBC in the blood in leukemic patient, we will find it very highly elevated in the blood. But when you measure the number of WBC in patient with lymphoma, it will be less as compared to leukemia. Why less as compared to leukemia? It is because lymphoma involve lymph node. So you will find the patient with a high number of WBC in a lymph node. And to insist, patient with leukemia, they less likely present with lymph node enlargement. They don't present with lymph node enlargement. Why? Because leukemia does not involve lymphoid tissue. But when you find a patient with lymph node enlargement, that is a lymphoma. The patient has a lymph node enlargement, and you check WBC, you find there is a significant rise of WBC number, and the patient has a lymph node enlargement, that is that is lymphoma. Again, to insist, we shall see what kind of lymph node, because when they are painful, it's not lymphoma. The lymph node which enlarge in lymphoma, they are painless, they are not painful. When you find the lymph node enlargement in a patient that which is painful, that is due to inflammation, and it's not neoplastic. Another thing I would like to insist, sometimes a patient can present to you with where you make a diagnosis of leukemia. You find a highly elevated WBC number without lymph node enlargement, and you can make a diagnosis of leukemia. Few months later, the patient can come back to you with the lymph node enlargement. What has happened? Leukemia has become lymphoma. Leukemia has changed into lymphoma. So it's possible for leukemic cell to change into lymphoma. Why? Because the leukemic cell, when they involve lymphoid tissue, that we say leukemia has changed into lymphoma. Okay, the vice versa is true. Sometimes you can find a patient with lymphoma, but later when the patient comes to you, there is no lymph node, or the lymph nodes, there is no lymph node enlargement, but the number of WBC in the blood has very highly elevated. What has happened? Lymphoma has changed into leukemia. So it's very possible for that thing to happen. So I'm sure for that introductory part you have captured a concept. Now, when we are discussing leukemia, as we said, it is a abnormality, neoplastic proliferation in lymphoid tissue. They can be grouped into two categories. We have Hodgkin and we have non-Hodgkin. Of course, Hodgkin, this is the name of the scientist who discovered this kind of lymphoma. So we have Hodgkin lymphoma and those which are non-Hodgkin lymphoma. So we shall see the characteristic of these which are known as Hodgkin. So to start, student, I would like now to discuss Hodgkin. After Hodgkin, we will discuss non-Hodgkin. Okay, Hodgkin lymphomas, we say by introduction, the general characteristic of Hodgkin lymphomas, they have bimodal distribution. Bimodal distribution in that they have two groups of which the incidence is high. Number one, they are common in patients with age between 15 up to 30. That is number one. After that, they tend to skip and they affect the patient with age above 50 years. So we found from 15 to 30, and they skip up to patient with over 50. So these are two groups of patients who are affected by Hodgkin lymphoma. That's why we say bimodal distribution. Another thing which I would like to highlight here is that this lymph node histologically divide the disease into four types. When we take a biopsy of the lymph node and send for histopathology, when they look on the histopathological appearance of this cell, they are divided into four types depending on how they appear on the histological examination. To start, we can have those lymphomas which, when we do histological examination, we find lymphocyte, that is many. We find many lymphocyte. That's we say lymphocyte predominant. So the first type or the first class of Hodgkin lymphoma is lymphocyte predominant. So when it is lymphocyte predominant, that is the number of WBCs found on the lymphoid tissue after histological examination, they are lymphocyte. And do you know the lymphocyte? We have B and C. So the most we found will be B cell. And these cells, they will have what we call a Redin-Steinberg cell. Redin-Steinberg cell we shall see in the coming lectures. The second category of lymphoid cell as far as histological examination is concerned. You will find those with nodular sclerosing. Of course, that is 70%. They occur more frequently in women. They have bands of collagen enveloped a pool of red Sternberg cell. That is, do you know the collagen? So you find that within the lymph node histologically, there are so many collagen fibers. That's why we say it's nodular sclerosing. So many collagen which envelope, they cover red Sternberg cell. Again, red Sternberg cell, this is a characteristic of Hodgkin lymphoma. I will discuss it as we are proceeding. The third is you find when you take a biopsy from a tissue and go for histological examination, you find that there are mixed cells. So that is mixed cellularity, and this counts for 25%. The larger number of red Sternberg cells, they will be of pleomorphic background, meaning they have a mixture of cells. And the last, as far as histological examination is concerned, are those which have poor lymphocyte. They are lacking lymphocyte. So that's the last category of non-Hodgkin classification on histological examination, and these are associated with worse prognosis. Those which are lacking lymphocyte associated with worse prognosis. So again, to insist, in Hodgkin lymphoma, the most common on histological examination is nodular sclerosing. It's nodular sclerosing which accounts for 70% of the cases. And the nodular sclerosing, we say there is a collagen which are found on the red Sternberg cells. Red Sternberg cells, of course, I will show you the pictures we were proceeding. So basically on staging, we say we can stage Hodgkin lymphoma into 4 stages. Stage 1, that's when we have the lymph node, we have single lymph node. There is no extra lymphatic site, meaning that we have a single lymph node and the lymph node is just on the lymphatic site. There is no extra lymphatic. Extra lymphatic meaning that you find the other lymph node within structures which are not the lymphoid tissues. The second stage, this is when there is involvement of more than 2 lymph nodes, but these 2 lymph nodes are found on the same side of the diaphragm. That is the second stage of the Hodgkin, the same side of the diaphragm, and we have 2 lymph nodes. Remember, classic, stage 1 was only single lymph node, which is not found in extra lymphatic tissue. The second class, we have second stage, we have 2 lymph nodes, but these lymph nodes are confined on the same side of the diaphragm. And the third is that we have 2 and above lymph node. You have lymph node which are more than 2, and these lymph nodes are found on both sides of the diaphragm. That is in stage 3. Remember again, we said stage 1 there is only 1 lymph node not found in extra lymphatic tissue. Stage 2, we had 2 lymph nodes, and these lymph nodes are found on the same side of the diaphragm. Stage 3, we have 2 and above. We have lymph node more than 2, and this lymph node, they are found on both sides of the diaphragm. And the last is when now we have lymph node in other tissues which are not lymphatic tissues. That is extra lymphatic site. You have lymph node which have disseminated to extra lymphatic tissues. That is to distant structure which are not lymphoid tissue. Again, to summarize, when you are asked to classify lymphoma, remember we say lymphoma are neoplastic proliferation of white blood cell involving lymphoid tissue. It is different from leukemia. Leukemia are neoplastic proliferation of white blood cell involving blood and bone marrow. I insisted how the patient present. A patient present, when you do a full blood picture, you find a highly elevated WBC and there is no lymph node enlargement, so you can say that is leukemia. And when you find moderately elevated WBC and the patient have lymph node enlargement, that is lymphoma. And this lymph node enlargement should be painless. When they are painful, it's not lymphoma. That will be, of course, that will be due to inflammatory process within the lymph node. But when they are painless, that suggests lymphoma. So when we discuss the lymphoma, can be grouped into two types. We had the Hodgkin and the non-Hodgkin. And non-Hodgkin lymphoma, this is a very small group of lymphoma in which the lymph node on histological examination, they have what we call red Sternberg cell. They have nucleus, they have two nuclei. So we shall see the picture of it. Kwa Kiswahili tunasema hizo seli zinaonekana kama zina macho kama bundi. Zina macho, unaziona kama zina macho mawili, macho ya bundi. So we say red Sternberg cell. Then how we group lymphoma, we said depending, when we do histology, we take a biopsy and we do histology, we can find the lymph node has many lymphocytes, that is lymphocyte predominant. And the second class, or when we do histological examination, we find many fibers around the red Sternberg cell, that is nodular sclerosing. And the third, we said, are those which has a mixture of cells, that is mixed cellularity. And the last was those lymphoid tissue which lack lymphocyte, that is lymphocyte depleted. And among those four, the common is nodular sclerosing, which account about 75%. So coming to staging, we said Hodgkin lymphoma can be staged into 4 stages. Stage 1 is when we have single lymph node. Stage 2, we said when we have 2 lymph nodes, but they are found on the same side of the diaphragm. Stage 3 is when we have more than 2 lymph nodes, but they are found on both sides of the diaphragm. And stage 4, well, that is when the lymph node has metastasized to non-lymphatic structure. We say extra lymphatic tissues. So coming to clinical features. In the clinical feature, we say the patient will have painless lymphadenopathy. That is, you have lymph node enlargement which are painless, and this is the most common symptoms, and it helps to differentiate from leukemia. Leukemia, they don't have lymphoid organ enlargement. Okay, may involve supraclavicular, so you need to palpate on the supraclavicular so as to identify if there is lymph node enlargement. You need to palpate the cervical, the neck. You need to palpate on the axilla, kwenye kwapa. You need to palpate on the mediastinum to see whether there may be mediastinal enlargement of lymph node. There's another issue which I would like to say is about spread by continuity from one lymph node to another lymph node. How do they spread? They tend to spread through lymphatic channel. You have one lymph node here connected by another lymph node by lymphatic system. So in your plastic cell, they shift from one lymphoid to another lymphoid. That's why we say they spread by continuity from one lymph node to another. So the symptoms, again, they are like of leukemia. We have fever. Why fever? Because the immune system have been compromised. When you have lymphoma, WBCs which are produced, most of them are defective, so they don't work properly, and the patient is at risk for infection. You have night sweat. Of course, night sweat just explain that the WBCs consume a lot of energy, and we need high oxygen so that to provide ATP and during night, so the patient will sweat so excessive as he use high energy to breathe. We have weight loss. Of course, weight loss is explained by high consuming of energy storage within the body. So you can have pruritus and cough secondary to mediastinal involvement. Okay. Another issue is when you do a biopsy of lymph node, as we said before, that you can take a biopsy and then go for histopathology to see the types of the non-Hodgkin lymphoma. This will reveal red Sternberg cell. These red Sternberg cell are required to say this is a Hodgkin, because any lymphoma lacking red Sternberg cell is not Hodgkin. They will be non-Hodgkin. So what are the Hodgkin cells? Hodgkin cells, this is a large cell neoplastic with two or more nuclei resembling eyes, macho ya bundi. Unaiona seli ni moja, kwenye histology ina nuclear zaidi ya moja. Unapoiona ina nuclear zaidi ya moja kama hivyo, ikiwa na nucleus zaidi ya moja imekaa hivi, maana yake hizi seli zitakuwa zinaonekana zina macho kama ya bundi. Ndio maana zilikuwa ni special seli ambazo huyu jamaa bwana Hodgkin aliziona. Ndio maana aina zote hizi za lymphoma akaziita Hodgkin lymphoma. So the presence of red Sternberg cell is very important to say this is Hodgkin. So ukikuta seli yoyote haina haya macho ya bundi itaitwa nani? Hodgkin. Zile zote zenye haya macho ya bundi zinaitwa Hodgkin. Kwa nini tunasema macho ya bundi? Ni kwamba ni seli moja na nyuklia mbili. Sasa hizi nyuklia unapoiangalia hii seli na ina nyuklia mbili ni kama unavyoona bundi. Okay. Usually they are B cell phenotype. As I said in the first classification, we had the lymphocyte predominant, and we said the most are B cell. May also be found in another neoplasia. If it reveals inflammatory cell infiltrate, it distinguishes Hodgkin from non-Hodgkin lymphomas. Inflammatory cells represent a reactive red Sternberg cell. These include plasma cell, eosinophil, fibroblast, T and B cell. Of course, these are mixture of cells which are not B cells. On chest X-ray and CT scan of the chest and abdomen, you may find the lymph node involvement. Bone marrow biopsy. When you do a bone marrow biopsy, you will find the involvement of the bone marrow. When you do leukocyte, you will find the leukocytosis, which are predominantly of neutrophic or neutrophilia. Treatment of non-Hodgkin consists of chemotherapy and radiation therapy to involve the following field. Number one, stage 1. Do you remember stage 1 of Hodgkin lymphoma? That's when we had a single lymph node. Stage 2. Do you remember stage 2? That's when we had two lymph nodes but on the same side. These are usually treated with a combination of chemotherapy and radiation, although chemotherapy alone can be acceptable for some patients. So remember, staging is very important because the treatment modality is based on the stage of the lymphoma. Stage 1, when we had a single. Stage 2, we had 2 but on the same side. That's when we use a combination of chemotherapy and radiation. Stage 3, do you remember stage 3? We said stage 3 we have 2 or more than 2 lymphoid organ or lymph node, and they are found on both sides of the diaphragm. And stage 4, that's where we had the extra lymphatic involvement, that the lymph node are disseminated in non-lymphoid organ. These require chemotherapy. And why they require chemotherapy? Of course, we said the one require chemotherapy and radiation, but all of this require chemotherapy. Combination of chemotherapy for non-Hodgkin, of course, it includes cyclophosphamide, and the second is hydroxydiazoxide, and the third is oncovin and the prednisolone. Of course, remember CHOP. P. As far as your level is concerned, of course, you will not treat this patient. You have to refer them to higher center when they will be treated, but you should know that they receive a combination of chemotherapy. But the treatment modality always do change depending on the standard treatment guideline. These are a picture of red Sternberg cell. Now you can see this is a cell, and this cell has two nuclei. This you can see, this is the nucleus, two nuclei, and this nuclei they look like always eyes, macho ya bundi ukiziangalia hizo cell. This is a characteristic for Hodgkin. If you don't find the cell having two nuclei resembling the always eye, that means if you don't find the red Sternberg cell, because this cell with two nuclei are known as the red Sternberg cell. If you don't find them on histological examination, that is non-Hodgkin. Remember, if somebody asks you, what is the characteristic of Hodgkin, which differentiate it from non-Hodgkin? That is the presence of the cell having two nuclei resembling the always eye. That is the presence of red Sternberg cell. So red Sternberg cell, when they are present, it signifies Hodgkin lymphomas, and when they are absent, that is non-Hodgkin. So to say that, I say welcome to non-Hodgkin lymphomas. We say the general characteristic of non-Hodgkin lymphoma, there is a device group of solid tumor which occur with the malignancy transformation of both the T and the B lymphocyte at their precursor cells. The type of lymphocyte involved and its level of differentiation determine the cause of the disease and its prognosis. That is the stage and the type of the cell will determine the prognosis and the treatment modality. We have the B cell lymphoma that accounts for 85%. That is, when we are talking of lymphoma, the most type of cell, lymphoid cells found, they are B cell, while the T cell lymphoma, they count only for 15%. The high, in most cases, they have B cell. Also, we have seen in Hodgkin, when we had the lymphocyte predominant, the most was a B cell. Again, here in non-Hodgkin, we say the most type of lymphocyte cell is B cell. The disease usually starts in a lymph node and spread to the bone marrow. As I said, we start within the lymph node because it's neoplastic which involves the lymph node, but it can spread to blood vessels, blood, and the bone marrow. That is, lymphoma can change it to leukemia. Non-Hodgkin is the sixth common cause of cancer-related death, of course, in the United States. These are the ones who do these researches. Non-Hodgkin is twice as common as Hodgkin. That means, but when we are discussing of lymphomas, the common are non-Hodgkin. Again, put that concept in your mind. If somebody asks you, as far as lymphoma is concerned, we classify it into Hodgkin and non-Hodgkin. Which one is the common? The common is non-Hodgkin, which is twice as Hodgkin. And remember, what differentiates Hodgkin from non-Hodgkin is the presence of red Sternberg cell in Hodgkin that make it different from non-Hodgkin. So patients with non-Hodgkin tend to have more advanced disease at the presentation than patient with Hodgkin. That is, a patient present in a very late stage. The mean age of onset vary with the subtype of lymph node of the lymphoma, but there is increased overall incidence as the ages increase. The risk factor, of course, HIV, immunosuppression, history of certain viral infections such as Epstein-Barr virus, and the history of Helicobacter pylori. Of course, in gastritis, it is associated with gastric lymphoma. So H. pylori eradication is very important when we are dealing with a patient with peptic ulcer disease, because if we don't treat it well, it can lead to gastric lymphoma. Also, autoimmune diseases such as Hashimoto thyroiditis and Sjogren syndrome, they also increase the risk of mucosa-associated lymphoid tissues. Classification of non-Hodgkin lymphoma. Of course, non-Hodgkin lymphoma, they are classified like when we are classifying leukemia. Remember, with leukemia, we said those which involve immature cell were very aggressive and they presented in a very early stage, and we said that was acute. And those which involve mature cell, they present in late stage, and we said they were chronic leukemia. So in non-Hodgkin lymphoma, also we say when they are immature, they present in a very early stage. So we are supposed to say acute lymphoma, but we don't say acute lymphoma. We say high grade. When we say high grade, it is equal to say acute. And when they present in a very late stage, that is chronic. So we don't say chronic lymphoma, but rather we use low-grade lymphoma. When we say low-grade lymphoma, it's similar to saying chronic lymphomas. But here we have intermediate grade. Of course, intermediate grade has been added recently. That means it is between chronic and acute. So remember, we don't use chronic or acute in lymphoma. We use chronic and acute in leukemia. But in non-Hodgkin, instead of saying acute, we say high grade. Instead of saying chronic, we say low grade. And we have intermediate grade, that is between low grade and high grade. Note, low grade lymphoma, the chance of the patient to be cured is very rare, because when these are matured cell, and when we give chemotherapy, remember when we are discussing leukemia, we said highly immature cell, blastic. When we feed them fake drug which mimic fake nucleotide bases, they are the one which are using nucleotide bases more, so they are likely to be affected with the drug. That's why acute lymphomas was very easy to treat as compared to chronic. And here it's very difficult to treat low grade, that is chronic. It's very to treat. Why? Because they involve matured cell, and the matured cell do not feed these, they don't need these nucleotide bases as for the cell to replicate. The median survival is between 5 to 7 years. Intermediate grade lymphoma, of course, 50% of patients can be cured by aggressive chemotherapy. Again, if you use aggressive chemotherapy, you can rescue 50% of the patient, and the median survival years without it. When we are saying median survival, that is without a treatment, you can go about 2 years. High grade, that is acute. We say 70% can be cured. Why? Because acute involve blast cell, and these blast cells are highly dividing. So when we feed them chemotherapy, they are the one which, if we take this drug very rapid, and hence they can die. And the median survival without treatment is just a few months. Again, I'm insisting, when I say median survival, that's when if we leave the patient without treatment, how long can the patient please survive? That is, in a low grade, we have seen, if you leave the patient without treatment, the patient will only survive 5 to 7. And in low grade, the patient can only survive 2 years. But in high grade, the patient can survive in a few months. Coming to clinical features, we say there is also painless. Remember, painless lymphadenopathy is typical for, it's common for all lymphomas. Lymph nodes are usually firm and mobile. Most involve supraclavicular, cervical, and axillary. Of course, it was the same as in Hodgkin. So you have to examine this site so as to see whether there is lymph node enlargement. Both symptoms are less common than in Hodgkin lymphomas. There are also electropollinatorial involvement, that is, it can involve the liver and the spleen, leading to hepatosplenomegaly. Of course, apart from that, we have the general complication as for leukemia and lymphoma. We have anemia. This is because we impair RBC formation. We have leukopenia. That is, we have low WBCs because most of them are defected, and we have low platelets. That is leukopenia because the bone marrow are producing more lymphocyte than platelet. Coming to diagnosis, of course, we need again to do a biopsy. And when you do a biopsy, of course, it should have no red Sternberg cells. When it has red Sternberg cells, that will be non-Hodgkin. You have to do CT scan and chest X-ray of the abdomen and the pelvis to show if there is involvement in this structure. That will be extra lymphatic involvement. Bone marrow biopsy is very important because it will differentiate Hodgkin and non-Hodgkin. Again, we checked for anemia, leukopenia, and thrombocytopenia. It's very important. Also, you have to check for liver function test to see if there is involvement within the liver. And also, you have to check alkaline phosphatase to rule out bone marrow involvement. Treatment modality varies depending on the stage and the subtype of non-Hodgkin lymphomas. But we say generally non-Hodgkin lymphomas are rare, curable, but about 5 years survival rate. This is in low grade, as we saw. Low grade, that is chronic, is very difficult to treat. Intermediate and high grade, of course, they can be treated as we said. Intermediate can be treated by aggressive chemotherapy. Also, high grade, that's acute, can also be treated by chemotherapy. And the median survival rate in intermediate was 2 years, but in high grade was months if the patient is left without treatment. Some patients may benefit from high dose chemotherapy with bone marrow transplantation. Sometime when the bone we may need to do a bone marrow transplantation. So this is a diagrammatic difference picture which show non-Hodgkin. Of course, we have indolent, or when you say very humble, when you have low grade, that is intermediate grade, that is high grade. Low grade, of course, we said small lymphocytic lymphoma, closely related to chronic lymphocytic leukemia. Why? Because they have mature cell, and then this also have mature cell. Prognosis eventually results in a widespread lymph node involvement with dissemination into liver, spleen, and bone marrow. Why? Because they are very difficult to treat. Intermediate, of course, these are diffuse large cell, predominant of B cell. As I said, there is a local invasion and present as a large extramodular masses. Of course, chance of cure is 75% with the combination of this drug which I said. The last is high grade. High grade can involve T cell, and many prognosis about in T cell we say about 50% of the patient have B cell, while 50 have T cell, and this can be cured with aggressive chemotherapy. And we have also a very special type of lymphoma, which is Bacti lymphoma. Of course, Bacti lymphoma is not a non-Hodgkin. This includes a B cell lymphoma, more common in children. Two types, we have the African and the American type. Remember, the Bacti lymphoma, it is different from non-Hodgkin lymphoma.